Good evening, everybody. Welcome to this discussion. Good evening, Ravi. Welcome.
Good evening, sir.
Yeah. Welcome to this discussion on soft tissue sarcomas. These are rare tumors, but nevertheless, they're so complex that the more I read about it myself, I get more confused. So I think it's time that we understand the basics, particularly for the postgraduates. I hope at the end of the session that we have understood the basics and the things that we need to know. It is a simplification, but I don't think it is an oversimplification in what I have put together in this presentation. And hopefully it'll clarify some of the doubts and thoughts that you have. And as usual, you're most welcome to pose questions and raise issues if you have any. All right. So what are sarcomas? I'm not talking about soft tissue sarcomas only. What are sarcomas? Nikita.
Sir, anything that is arising from mesenchyme, sir.
That is true. So when you read a chapter on sarcomas, one of the things that they say is it arises from the mesenchymal tissue. Are there anything else that they describe in the very first paragraph?
Anything other than epithelium and
That's the same as mesenchyme.
yes.
Yeah. What is very important is that they're very complex and heterogeneous. All right. So it's not, carcinomas seem to be a lot more straightforward, but not so sarcomas. And a wide variety of tissues give rise to this. And there can be those arising from bone or from soft tissues. Bone also is mesenchymal tissue. The two are completely different, and so they're considered differently. And soft tissues themselves have two broad categories. One of them is retroperitoneal. The other category is the ones that arise on the extremity and the trunk. Trunk and extremity behave similarly, but because of the anatomical nature, while their biological behavior may be similar, there are little differences. And trunk is quite uncommon. And so today's discussion will be on soft tissue sarcomas on the extremity. I have not included retroperitoneal. If you want, I can have a separate discussion on that some other day, or you can read it up yourself, depending on what your requirements are. Okay. So are they common in adults? We are adult surgeons usually, or is it more common in children? Praveen.
Sir, it's common in adults, sir.
Anybody wants to differ?
It's in children.
All right. So if you answer that correctly, that is the correct one. You then have to give me some data. How uncommon is it in adults? How much more common is it in
I think it depends on the type of tumor, sir.
It's true, but generally there is a ballpark for everything. Very true. That's why the first word we used was heterogeneous. Okay, this is the kind of difference. Okay, 1% of all cancers in adults only are sarcomas, whereas up to 15% in children can be sarcomas. Right? That is the data. If you don't know it, it doesn't matter, but that is how uncommon it is in children. So I'm not talking about individual tumors. Again, I concede straight up that these are heterogeneous, but there are certain peculiar features of STS as compared to carcinomas in general. All right. Again, please don't tell me subtypes. It depends. It does. I agree with that. But there are certain recognized common features. Can anybody take a guess on that? Vinod?
These are hematogenious spreading tumors, sir.
All right.
And what I observed is all the carcinomas, they mention in TNM stagings, and these stagings, every tumor has its own classification, and more of them are dependent on grades of the tumor and mitotic index of the tumor.
Why do you think it is? You're right. Why do you think it is? Why would one worry more about the grade and the mitotic index?
Because they're very aggressive, sir.
Correct. Yes. All right. So the peculiarities are that they're aggressive, they're heterogeneous, and because they're aggressive, there is a higher propensity for recurrence as well as metastasis, okay, compared to carcinomas. And that is why, as you rightly pointed out, that there is TNM staging for sarcomas also, but it is not very popular, not universally accepted. So there are other methods, and we'll of course cover that as we go along. Okay. So just to know about a little bit about epidemiology, I think it's nice to know about age distribution. I'll probably not ask you this and put it up myself. In adults, it's usually between 50 and 70 years. We talked about many types of sarcomas. The adult varieties are liposarcoma, leiomyosarcoma, GIST, and pleomorphic sarcoma. How many types are described? Do you know approximately of sarcomas?
50 to
55
70
subtypes.
sometimes.
Correct. So, as you can see, I have mentioned the common ones, which are only 5 or 6. In children, the major types are rhabdomyosarcoma and fibrosarcoma. Okay, more than 50 types of sarcomas are there. They're all very rare. As you can see, the overall incidence in adults is only 1%. Of that, if you have 50 or 70 types, subtypes, then you can understand that the volume load of even specialist centers which deals with sarcomas is very small. And so not the final word about what is the correct treatment and what is the kind of regimes that we need to have, what is the prognosis for each and every subtype of sarcoma is not available. That's why everybody bunches everything together. And so the information we know and we can share with the patient is somewhat limited. And so that uncertainty of prognosis, outcomes, mortality, morbidity, all that has to be tinged with a degree of uncertainty, and that has to be conveyed to the patient when we deal with these diseases. Location. Where would these location in the body, where would these things occur, you think?
Similarly in the limbs, sir, and
Already we have
particularly lower limbs.
Sorry?
More common in
Extremity.
lower limbs,
Okay.
and then
Correct.
trunk and in the retroperitoneum.
All right. So this is the order in which it occurs. Can occur anywhere. Extremities are more common. 45% of them occur in the thigh. Okay, it's a large number. Next comes visceral, then retroperitoneal. Visceral because GIST is a kind of a sarcoma.
Yes, sir.
Okay, leiomyosarcoma. These are things that occur in the visceral area. Next comes retroperitoneal. As you can see, truncal is way down. You mentioned truncal after extremities. That's not the case. It's way down here, and then thoracic. Intrathoracic tumors or sarcomas are perhaps the least common of all sarcomas. All right. So, are there any predisposing factors? Recognized predisposing factors for this? Samir, you've done some reading. Most books will give you this, list this. Are you there? Can you unmute?
Yes, sir.
Go on. If you don't know, say you don't know. We'll just go to somebody else.
No, sir.
You don't know. Okay. Sanya, you want to have a go at it? Predisposing
Yes, sir.
factors?
Few genetics are one of them.
Yes, very good.
It could be a lot of usually seen in associated with a lot of syndromes.
Correct. Very good.
It could be sometimes it can be because of few viral infections, sir, like HIV.
Yes,
associated with them.
excellent. What is the HIV associated?
Kaposi sarcoma, sir.
Yeah. For some strange reason, you don't see it much in India. It's described
Yes,
in the
sir.
books, common in
Yes,
the
sir.
West, but not in India. I don't know why. Yeah, go on. Very
Yes,
good.
sir. And lymphangiosarcoma in the post-MRM lymphedema that we see can
Yeah,
include them.
excellent. So genetic, which is rare, prior radiation, this vinyl chloride dioxin are very commonly quoted. These cause angiosarcomas, okay, vascular sarcomas, chronic lymphedema that Sania mentioned, and HIV and Kaposi sarcoma. There are many syndromes. I never bother you with, asking you to name them, but then I just put it up on the slide to say that there are genetic syndromes, but they're rare. Please understand that sarcomas are very rare diseases, and the genetic predisposition is even more rare. So please note, WHO has classified soft tissue tumors. I'm switching gears a little bit. I'm asking only for sarcomas, and I'll give you a hint. It has to do with the biological behavior. So what do you think there are subclasses in it, but what are the major classes that WHO recognizes?
4 classes, sir.
Yes.
Benign,
right?
Intermediate,
Right.
intermediate 2 types and the malignant one.
Yes, you've read it up. That's good. Okay. Why would you think that WHO mentions this? Intermediate local recurrence, intermediate rare. Why did you even think about classifying it like this? What is the logical basis behind this?
Treatment, sir?
Treatment, not so much. See,
More
this
malignant potential, sir.
there is a spectrum, there is a continuum. Okay, so when you see a tumor, a soft tissue tumor, it's very difficult for us to categorically say this is definitely malignant, this is definitely benign. Those two extremes of the range are, of course, there. Some of them you can easily clearly say. But also, there is a group of diseases which arise from the same tissue, lipoma. There is a lipoma, there is a liposarcoma, but there is also an intermediate phase or intermediate entity where pathologists find it difficult to say what exactly it is. IHC can help it a little bit, but it is still not the final word. So when you deal with large soft tissue tumors, you must always have in mind that there's always a malignant potential, even if it is reported as a benign disease. And its clinical implication is that you've got to keep them under follow. Okay? As long as you keep them under follow-up, then the patient knows and you know that you are keeping an eye on this fact. You're reacting or acting on this fact that there is a little uncertainty in the final diagnosis. I'm giving you examples of my own. Large lipoma. It's also in the deep tissue, you can see. It turned out to be a lipoma. Okay. We operated on him and took it out. It shelled out very nicely. I had him on follow-up for some time. And now that he's okay, I've told him not to worry. And so I'm not seeing him anymore. This is a patient still on follow-up. This is another intramuscular lipoma, which is on the medial wall of the axilla. Are you seeing my pointer?
Yes, sir.
Yeah.
Yes,
So
sir, yes,
this
sir.
is the head of the humerus, the chest, and this is the medial wall of the axilla, as you can see. So we took this out. It's an intramuscular lipoma under follow-up now, and it's quite normal. This was some variant of a fibroma. Okay, it was on the acromioclavicular joint. This is the shoulder and the acromioclavicular joint. We shaved it off the joint. It was such a big tumor. It was so tight in that area that we had to graft him. And this was fairly recent. I don't know if you can see the date on this. It was just a few months ago. So he's also under follow-up. The wide excision was done. This was a synovial sarcoma, which we excised completely. It came back as a sarcoma, but of a low malignant potential and low and a risk of local recurrence, not metastatic disease. So we excised the whole thing, and of course we sacrificed one of the extensor tendons, which had really no great disability in the functioning of the hand, and he also did well. This was done some time ago, and so he's not under follow-up anymore. This was a patient who came to us with a large groin sarcoma with secondaries in the lungs. Elderly lady, and we just sent her for palliative care after a diagnosis, after a core needle biopsy and diagnosis. Really, nothing could be done. I mean, they are also of a lower socioeconomic group, and they offered them palliative chemotherapy, but they didn't take it, and I had no objection to it. But I do not think anything would have helped her much. So palliative care is what we offer. So the point I'm making is you can have large soft tissue tumors which have a degree of continuum between a benign nature and a malignant nature, and you must keep them under follow. So what is the kind of classification of soft tissue sarcomas you know of? Anybody? I think I should be more specific. Praveen.
Sir, based on the connective tissue, sir,
Okay.
adipose,
Yeah.
it is subdivided into
Correct.
benign, malignant.
Tissue of
Fibrous-
origin. Tissue of origin is a better way of putting it. Yeah. Okay. Agreed.
Yes, sir.
Okay. Okay. What else? Anybody else? Nikita?
From
All
the
right.
fibroblast.
So based on histology and IHC characteristics. Tissue of origin, histology is that, but you must add the IHC characteristics to it. As we said, more than 50 types identified. Please remember that all of them have distinct clinical course in behavior. So you can't possibly remember all that. And so if you get a biopsy and get a tissue type, you have to go back to the books to know what its biological behavior is. And as I said, these are the common types, and I'm not going to repeat it. It's about the same as what we had, nearly the same as what we had listed earlier. Grading is what we mentioned. Why is it important? Grading.
The potential, sir.
Sorry?
Malignancy potential of the tumor.
Okay. Yeah. I'm talking about sarcomas here. Okay. I do agree. I am switching between benign and malignant, but in this STS means soft tissue sarcoma. So we know it's a malignant disease, no doubt. In that grading, why is grading important? Sorry?
Severity and metastasis and recurrence.
Though the size is small, if the grade is high, we have to consider it
Grade it
as
as
a
high.
high.
Right. So metastatic and recurrence potential and prognosis, mortality. So when you have a higher low grade tumor, they do well. And when you have a high grade tumor, they do not do well. It's very simple, no rocket science in that. Another thing that you have to add is the choice of treatment that you have. Okay, in the multimodal treatment that we are coming to, but the choice of treatment you have is to quite some extent, to a large extent, dependent on the grade of the tumor. So you really are dependent on the pathologist a lot in soft tissue sarcoma. So what do they base the grading on? What do the pathologists base the grading on? There are some factors of the tumor that they look at.
Mitotic index.
Mitotic power.
Correct.
And necrosis and
correct.
And pleomorphism.
Good. Okay, those are the three things. Differentiation, not more than pleomorphism. How de-differentiated it is or differentiated it is, mitotic figures and necrosis. Okay, the NCI, National Cancer Institute, Sloan Kettering, they all have their own gradations with slight differences. The common one is the French one called FNCLCC. There is a French expansion of it, and I don't bother to remember that. That is the one that's most commonly used. Okay, and it is based, the latest addition to the whole group to make it even more complicated is that they are grading the tumors on, not all of them, but many of them are gene mapped. Many of the tumors are genetically mapped. And so they're basing the, pathologists are basing the classification on genetic features as well. But that is work in progress. It's not commonly applicable in clinical practice. What is used in clinical practice is most commonly the French system of grading. Okay, clinical features will relate to these three major phenomena associated with the tumor, related to the lump, pressure symptoms, and metastasis. Can you name one or two symptoms for each of those? Ines, have a go at it. Okay, let us look at a clinical feature of a sarcoma in the thigh, because it makes it, I'm making it more specific.
Like it could cause like compression symptoms. The patients could complain of.
No, I've talked about pressure symptoms as a separate one. So what is the first one related to the lump itself? Presence of the lump is the first one, right?
Yes, sir.
You will have a lump, okay?
Yes, sir.
Where can it be? What are you interested in there? When you look at the lump, what are the things that you look for in that lump? Like any other lump.
So the location,
Yes.
its mobility, its
Yes.
consistency, the margins.
Correct.
Like if there is any discoloration or
the two things that are most important in sarcomas, you have kept to the last. I know you will say it, but it should come first. Okay. After the size is important. If it's a small lump, it's unlikely to be sarcoma. If it's a big lump, it's likely to be sarcoma. Okay. Size is important, and the plane of the swelling. If it is subcutaneous, it's unlikely to be sarcoma.
yes.
Note the word unlikely. I'm not saying it cannot be. If it's an intramuscular deep lump, likely to be a sarcoma. Okay, plane
Yes.
of the swelling. And very characteristic of sarcomas, which is described by all the books, The
Increase in
nature
size.
of the skin over the swelling. What is it? What does it show? In a sarcoma, all the clinical method book says that stretched, shiny,
Pinchable.
erythematous, and showing vascularity. Okay, it shows prominent blood vessels. So if you have a lump in the thigh, for example, which has a stretch, which is large, skin over it stretched, shiny, perhaps a little reddish with prominent blood vessels, think of a sarcoma underneath. Okay, these are the features related to the lump. What would be the pressure symptoms like, or infiltrations?
So there could be pain.
Pain. Okay.
Patient could have swelling or features of numbness as well.
Yes.
Then
Pain in the lump, pain radiating towards the distribution of a nerve that may be pinched or infiltrated. Okay, what else? If it is near a
Restriction
joint,
of
for
mobility.
example, what happens? If it is a pressure on a joint or a big lump near a joint, what happens?
pathological fractures.
That's very
Restriction of
rare.
mobility.
That's all. The range of movement of your joint will be much less if it's a lump sitting near it. And metastasis, where do they metastasize to commonly? Sarcomas.
Lungs.
Sir,
Lungs. So what would be the features?
cough and hemoptysis.
Correct. Cough, hemoptysis, breathlessness. Okay. And you may have an effusion, and that may cause further compromise of breathing. Okay. So these are the clinical features that one comes across. Now, of all the features that we're talking about, there are some red flags for a lump. We talk about red flags for a GI disease, you know about it, like loss of appetite, loss of weight, hematochezia, melena, things like that. What would be the red flags for a lump, particularly in relation to a sarcoma?
So lump greater than 5 centimeters,
Okay,
increasing in size,
good,
deep to the fascia, and painful.
excellent. Yes, you got it, everything, almost everything. Recurrence after removal is another addition, but yes, that's it. You said 5 centimeters. It's true that the TNM staging looks at it as a 5 centimeter mark off. But if you look at radiology literature, for some strange reason, they talk about 4.3 or 4.6. They're very precise. The reason that is so is that they have correlated their size with the histological features. And many studies have shown that 4.3 or 4.6 centimeters seems to be a good cutoff for a good fit. They do this area under the curve kind of analysis. So because of that, they've looked at, but I agree. I think anything which is more than 5 centimeters must raise your antenna regarding the lump being a sarcoma. Ravi, you want to add anything?
No, sir, I'm just listening.
Oh,
The
good.
other,
Sorry.
can anyone name the soft tissue tumors which metastasize to lymph nodes? Some of them have common predilection to, apart from.
You can ask it now, but there's a lump on it. I mean, there's a slide on it, but you can go ahead. Yeah.
Okay.
Rhabdomyosarcoma, sir.
Yeah, correct.
Rhabdomyosarcoma, clear cell sarcoma, and
Correct.
and malignant
Synovial.
Synovial sarcoma.
Sarcoma.
Angiosarcomas. Okay.
Yes.
Common ones. Okay. Synovial, angiosarcomas, rhabdomyosarcoma, and clear cell sarcomas. You're right. Rajesh Ballal is there. Rajesh, welcome.
Good evening,
Nice to
sir.
see
I'm
you.
enjoying myself, sir. Good
Please,
evening.
and if you have anything to add, please.
No, sir. No.
Yeah, anytime. It's lovely to have you. Yeah.
Sir.
Okay, so how do you work up these cases with a suspected soft tissue sarcoma? Samir, you're very quiet today, man. You must have. Did you read up about it? Tell me. Did you honestly tell me? Did you read any chapter, any book on this?
I will answer it. He hasn't.
He hasn't. Is Ravi correct? If you're not read, I won't ask you. That's why it's as simple as that. Samir, answer me, please. Have you read?
Sir, from PubMed, I've gone through, sir, when I came back. But
You saw the titles of the articles. All right. Ainas, you didn't read the articles. Ainas, have you read any chapter or any book on soft tissue sarcomas?
Diksha, yes, I've just gone through a little bit of Bailey and Shaw's.
it's this kind of discussion
DVTA.
becomes a discussion only when you guys read up and come. Okay. And you're postgraduates. I'm not here, giving you a smack on the wherever. but even though I'm laughing at it, I don't think it's a laughable matter. You guys want to get the benefit of a talk, of a discussion like this, you must read up and come. Okay.
Muniredi sir has bought a new edition of DVTA. And
Oh, okay.
It is both academic and physical exercise because he says it's quite heavy.
Heavy.
So
All right.
I think you guys have to read. I think you get this one web version of DVTA, which I think is downloadable. I think you should all have it, and you should read it. Especially, I think soft tissue tumors is very important because I think DVTA is probably the final authority on that.
All right, Praveen, can you tell me what would be the steps in a workup? Starting with a clinical examination. Yeah. Just tell me the steps. Like you see a lump in, see an outpatient, what would be the steps that you would undertake? Give me the headings.
Sir, we'll do the inspection palpation part, sir.
Even before that,
clinical examination
apart from what else would you do apart from clinical examination?
History.
Yeah, because you see, this is the approach that a surgeon has for any, you do a clinical examination. Okay, then have to do imaging. Why would you do an imaging?
So imaging will start with ultrasound, sir.
Why would you do an imaging? We'll do all that. Why would you do an imaging?
Sir, to know the extent
of the disease. Correct. And to stage it, whether it is a metastatic or not, you would look at that. Biopsy and histology to characterize the disease. And then, as I said, putting all these three things together, you stage the disease and then you decide on the treatment. All right, it's as simple as that. So I'm not going into the clinical aspects in detail because I've mentioned it already. You just have to look at the lump, look at the possibilities of, examine the chest, examine the abdomen, in rare cases, the lymph nodes. What is the purpose of the imaging? Again, I'll come to the specific imaging later. I've already mentioned one or two of it now. What else is important in imaging a disease like this? Praveen, I'm with you still.
Sir, it
Okay.
helps to evaluate.
You have to get the characteristics of the tumor. If it takes so long to answer, then it will go on forever. So you need to just start reeling off. You want to characterize the tumor, you want to get a biopsy, and many times you may need an imaging modality to direct your biopsy. Okay, image guided biopsy. As I said, it helps you to stage the disease, and once you have given the treatment, the imaging also is required for you to assess the response of the tumor as well as recurrence. Okay, any recurrence if there is on the follow-up period. So the important thing is every kind of modality of imaging that we use, we must know its value and where, in which part of it or all parts of this kind of steps, whether it is useful or not. Okay, that's the important thing. Some of them may not be useful in certain of these steps. Some of them are required for all these steps. So we need to understand that, and before we go into the individual things, okay, we have to look at what are the things that we use. So what are the things that we use? You mentioned started with ultrasound. I have started with ultrasound. What other imaging can you use, Praveen?
And CECT.
Sorry?
MRI.
MRI, CECT, okay. Why? What contrast? CT anyway, okay. What else can you use? PET CT has a
Plain
role?
X-ray and PET CT, sir. Yes.
Okay. So plain X-ray, I think can be used, but it's probably gone out of the wound, gone out of the armamentarium after we got the MRI. All right. So what plain X-ray tells you is much less than, but nothing wrong in doing an X-ray. I have not even included a slide on plain X-ray because it's a soft. Remember, we talked about soft tissue tumors. Only when you have a suspicion that it's a bony tumor, then you would say a plain X-ray could be considered. So what would an ultrasound tell you when you're doing it for a soft tissue tumor? Nikita?
So the size of the swelling,
Correct.
depth of the swelling,
Correct.
and the margins and characteristic features.
Correct.
Yes, sir. We can even comment about the malignancy features also.
What is the commonest? Yeah, you're right. What is the commonest thing that ultrasound is good at? We all talk about it in all locations. Whether it is cystic or solid.
Yeah,
No,
consistency.
anything with ultrasound, just remember this. Ultrasound is very good at differentiating between cystic and solid. And it's a lot more accurate when the lesion is cystic, less accurate when it is solid. Okay? That is about ultrasound. It's common for ultrasound everywhere. Now, how sensitive or specific do you think ultrasound is?
70%, sir.
Yeah.
Sensitive.
All right. I'll buy that. This is the idea. So I have given the description that is classically given in a soft tissue tumor ultrasound. Okay. But focus on the left corner of all, left side of all these findings that I have put. Okay. Size, consistency, plane, vascularity, and surrounding vessels. Okay. Neurovascular bundle. These are the things that it says. And as you quite rightly said, sensitivity is not very high, about 70%. So in this particular ultrasound, the sonologist had reported as a 7-centimeter clump, which is solid, deep to deep fascia. It is vascular, and the flow in the surrounding neurovascular bundle or adjacent neurovascular bundle is normal. So even though ultrasound can be done as an initial test, MRI is probably the investigation of choice. Before we go to that, as you said, you told me that you can differentiate, you can say whether it is benign or malignant on ultrasound features. You're quite right. But again, remember the sensitivity does not change. It is still 70%. So if you have a lump which is less than 46 millimeters, which is avascular, exception being hemangioma, well-defined margins, not deep but subcutaneous in location, then you can say that it is benign, right? If there are other things, okay, then if it is other than what is listed on this thing, then you must have your antenna, as I keep saying, antenna going up, say that it could be malignant, okay? So what would MRI say, or what information would it give, which an ultrasound does not give? What is the okay? Let us start
So
with the
association with the neurovascular structure.
Let us start with sensitivity and specificity of MRI as compared to ultrasound. How much is that?
95, sir.
Correct.
90.
Correct. That's all it is. And the characteristics that it gives are nearly the same, but the definition is much, much, much better. That is an important thing. Why would definition be important for you? Why would definition be important for you?
To categorize, sir.
No, it cannot categorize. See the last line in my slide. It cannot tell you what kind of a sarcoma it is. You have to have histology for that.
Size.
My point, I'm pointing a pointer to one item there. Can you see? Did you see that? What am I
Yes,
pointing?
neurovascular bundle.
Correct. So when I say definition is important, why would I think about neurovascular bundle?
Involvement of adjacent structures would be very clear in this.
So it has to do with the resection. For a surgeon, this information is very important, and ultrasound doesn't provide that, but MRI does. Okay. So I'll tell you one of the principles of soft tissue sarcoma resection is that you must give a 1 to 2 centimeter healthy normal margin. The location may be such that you cannot give it because there's a neurovascular bundle nearby, in which case you really have to shave it off the neurovascular bundle. And whether you can do surgery or not depends on the definition of the tumor and its relation or proximity to the neurovascular bundle. And that has to be defined. Otherwise, you have to do something else. We'll discuss that later as we go along. So this definition, soft tissue definition being good, is very, very important. And that's why MRI is the investigation of choice. Bone involvement can be seen. Okay, what would it show in a bony involvement in an MRI?
Destruction of bone cells.
Correct.
Edema
Cortical destruction. Very good. Edema around what? You're right. You actually got the answer. Two structures, periosteum and endosteum. That is a marrow. Okay, so if you have bony destruction, periosteal reaction or endosteal reaction, then there's likely to be some kind of bone involvement in the sarcoma. And the MRI is capable of doing that, but for these definitions, CT is better. That's about the only thing where CT is better. CT defines bones better and MRI defines soft tissues better. Okay, I'll get along with this. It is inferior to MRI, as I said. Okay, and as I said, for detecting bony involvement, the three reactions that I mentioned about, they're detected better in CT compared to the MRI. And of course, CT is also good for metastatic workup of the lungs. When it goes into the chest, it helps you there. And you mentioned about a plain film. Okay, I put it up even though we don't routinely do it. I put it up here. What does it show that tells you that this is possibly a sarcoma? Nikita, you mentioned CT. Bony destruction is one which a
Yes,
plain
sir.
film can show. How does this tissue look? Does it look like just a soft tissue shadow, or is there something else in it?
Calcification.
Yeah, there is a kind of a diffuse calcification in it. When that happens, it's likely to be a sarcoma. And that does show on plain film, but it's much better to do an MRI and it will show up very well on the MRI as well. PET CT in STS, not recommended routinely. It's not really recommended, but it can help you in staging and prognosis. It will help you in response to treatment. As I mentioned, it is not recommended, as you know, every patient with a soft tissue sarcoma, you do not go and ask for a PET CT unless there is a definite reason for it. And one of the most common indications for PET CT in sarcoma is response to treatment and recurrence. If you're suspecting recurrence somewhere, you want to know if it's metabolically active or not. But this recommendation, I've seen the guidelines as well, it's probably going to change because this is being pushed in a big way. Okay, diagnosis and classification is one, but staging and prognosis. How do you think the prognosis can be detected on PET CT? Vinod.
The tumor, sir, again.
How do you think prognosis can be detected on PET CT? They're pushing it now. It's not completely
Amount of avidity, sir. Like
metabolic
the
activity.
amount of
What you should.
Activity.
So
activity.
now they're now trying to correlate the metabolic activity with the aggression or the aggressiveness of the tumor. And there are studies which are now saying that if it's a metabolically active lesion, then it's more likely to be have worse prognosis and have a worse staging at the initial stage itself. Okay, but I insist there is no recommendation for getting PET CT as an initial workup, but if you're looking at recurrence, that's one area where it can be helpful. Okay, we mentioned about staging. HSCC or TNM staging does exist. And as you know, the N there stands for a lymph node. And because sarcomas do not normally go to lymph nodes, we mentioned a few which do, but by and large, HSCC is not the preferred kind of staging. The two other stagings that people use are the ESMO, which is the European Society of Medical Oncology, where they have developed nomograms. They feel that the prognosis can best be described by these kinds of nomograms. And so obviously you don't remember these things, you just have to know that they exist. So when you have a particular histology of a tumor and a degree of, degree of workup as far as its extent and its by imaging that you have, then you can refer to these nomograms and then see how the prognosis holds out. Okay, so ESMO recommends that. This is the TNM staging, and the cutoff, as Praveen said earlier, is the 5 centimeters. T1 is less than 5 centimeters. T2 is more than 5 centimeters. N not very important. And so because of this, as I said, this is not very commonly used. But one of the commonly used things is a Sloan-Kettering staging. Okay, where they also have 5 centimeters, but they include whether it is superficial or deep. And they have this complex method of not very, less complex than TNM or the other nomograms, for example, of looking at factors which are favorable and not favorable. Again, based on the, as we said, the grade, the necrosis, and the mitotic figures. And so based on that, they give you a prognosis. As I said, I do not remember. I do not expect you to remember any of this, except to say, to know that these things exist. And so when you have a given case, just go to the literature, go to the books and look up these things, and then give an accurate grading and staging for your disease, so that you decide on the correct treatment. And when somebody else is seeing, some other surgeon is seeing it, he knows on what basis you chose the treatment that you recommended. So, go on.
Actually, previously there used to be the staging, grading called Enneking classification.
Correct. Enneking is also there. Correct.
But that was very good. I don't know why they have replaced it. It was universally applied and it actually encompasses the same thing. But I think they have reinvented the wheel as far as this is concerned.
You're probably right. I also remember the name Enneking, but the present, if you look at the latest literature and guidelines, they don't mention Enneking at all. Okay, that's it. You're right. You're absolutely right. So, if I want to do a biopsy, what are the choices I have, Praveen? Are you there?
Yes, sir.
Praveen? Sorry?
Incisional biopsy and excisional
ultrasound.
biopsy.
No. Just tell me. One. Go on, Praveen.
Using ultrasound guided.
Guided or
For
otherwise
needles.
depends. That guided or otherwise depends on the location, depth, and the certainty with which you can hit it. Okay, that's fine. But what are the choices that you have? What are the kinds of biopsies one can do on a lump? There is no more rocket science in this. I'm sure you know this. You're hesitating to answer.
Excisional biopsy and incisional biopsy.
Excisional.
You would straight away mention that in any tumor. Would you do an excisional
Core
biopsy?
biopsy. Core biopsy first.
Yeah.
Core biopsy.
Fine needle biopsy.
So these are your choices: FNAC, core biopsy, incisional, and excisional. FNAC is not accurate, but you can perhaps use it for recurrences. You already know what the tumor is, and when it comes, and particularly if it's in very deep areas where you cannot access it easily, you may consider it. But the method of choice is core needle, okay, a true cut needle biopsy. And the important thing is you can do an IHC on it. As I told you today, characterization of any sarcoma is not only by histology, but also by the IHC. And in the coming years, maybe in the next 5 or 10 years, or even earlier, perhaps, I don't know, we may also go for a genetic study, genetic profiling of your sarcoma. So if you want to go beyond this cellularity, which you get in FNAC, if you want to look at the architecture of the tissue, you want to look at IHC, you want to look at genetic studies, you have to do a core needle biopsy. That is the best. Okay, less invasive, not non-invasive, less invasive, and gives you all this information that you need, and then you can plan the treatment. But you need to do an incisional biopsy when core biopsy fails. Okay, if you don't get the information that you want, which is essential, then you need an incision biopsy. So when you do either a core needle biopsy or an incisional biopsy, you have to plan your incision well. What do I mean by that, Sanya? Is Nitya here?
sir.
Is she on call or something? Is she busy? Nitya here?
So
She's
ma'am
on
is a
call, sir.
GR, sir.
Sorry?
Yeah. She's an emergency, sir. She's on
All
call
right.
today.
Okay. Emergency working or emergency sitting?
There's a one.
No, sir,
There has
working.
been one case.
Good, good. No, I'm just joking. Yeah, go on. Tell me,
Sir,
Sanya.
yes, so when we are planning for an incisional biopsy, we have to
Yeah.
plan an incision in such a way that when we are planning for a complete excision, that should be included.
That's
Because
it.
most of the times that incision, wherever we take it from, is contaminated with the malignancy.
That's all. Okay. Either when you do your core, where you choose to put your needle, or where you put your incision, you have to include that in your subsequent incision. Now, if you're excising something, what is the kind of factors that you have in mind in putting that particular incision for excision of the whole lump? We'll talk a little bit more when we come to surgery, but at this point, it's good to know that.
So
You
can
have
you
to
repeat
have,
the
yeah, you
question?
have to have complete excision of the tumor, right?
Yes, sir. Yes.
So what are the things that you have in mind when you make an incision to achieve that? It's not only the tumor, you have to look at some other thing also when you make your primary incision. It's no great, not rocket science, but what else would you bear in mind? Sorry? We keep on talking about the neurovascular bundle,
Yes, sir.
right? So when you
Yes,
make
sir.
your incision, it should be in such a way that if required, you will be able to get control on the vessels also.
Yes, sir.
Apart from making the tumor. So when you hear at this point, when you're coming for a biopsy, you have your imaging. So you know where the tumor is, where the, if any, whether there is any neurovascular bundle nearby. Then you think about where, when you're excising this tumor, where you would put your incision to cover both complete excision of the tumor as well as control on the neurovascular bundle. Then you put your excision, your incision for excision. So you have that in your mind, and then within that ellipse that you make, it could be horizontal, it could be vertical, it could be oblique, whatever. Within that, incision that you're going to have later, put your incision or your needle. Okay? It is as simple as that. Understood that?
Yes, sir. Yes, sir. Got it.
Yeah. So that's as simple as that. Okay, excisional biopsy is not very common. Most of the time, you'll end up you'll end up doing an excision thinking it's benign, and then you will end up having a histology of malignancy, and you probably have to go back and do a wider resection. That's what happens. But excisional biopsy is mentioned for the sake of completion, but most often done for very small tumors. Histopathology and IHC go hand in hand in sarcoma diagnosis. Only histopathology doesn't give you the diagnosis. It will give you a broad idea whether it is from a lipid, lipomatous tissue, or whether it is from muscle or from synovium or whatever. Does those things. But IHC markers are important for proper characterization, which again has an impact on the further treatment that you have, particularly non-surgical treatment that we use. This is something which I learned only recently when I read up about for this talk. The IHC markers that we use are of three kinds. These look at transcription factors, protein correlates, gene expression profiling. So I don't think it's important for you to know these things, but I found it interesting that these are the kinds of IHC, I suppose you can call it media or markers that people use to get more information or classify more accurately the soft tissue tumors. Okay. Anything to add so far, Ravi, Rajesh, Shrikant? Yeah.
No, sir, I think very correctly said they must plan your incision. That was very nicely put in the previous slide, sir.
Yeah.
That is important for them, I think, sir.
Yeah.
And no place for an FNA also, sir.
Correct. It's really mentioned for the sake of completion. Yes, I agree. Treatment goals. So again, I'm not looking at individual treatment. What are the goals that you would have as a surgeon, Vinod, if you see a patient with a sarcoma?
Excision, complete excision and prevention of recurrence.
Okay.
And if the joint something is involved, as much as possible to prevent restriction of mobility.
Okay. Anything else? Remember, we're talking mostly of extremity sarcomas.
Yes, amputations.
What about amputations?
To avoid
an amputation. Thank you. Yes. I'm glad you mentioned that. Okay. Achieve local control. That's a very important thing. Preserve the limb. Avoid amputation. When I was a student, amputations were very common. What I have seen a sea change. Treatment of sarcomas is there's hardly any amputation nowadays. That is the main thing. Okay. And try and prevent metastasis if you can. Please understand that really is a multidisciplinary subject. It's not theory where you look at the tumor board. In sarcomas, because it is so diverse, information is not so prevalent or understood. The disease is not very well understood. So as a surgeon, you're duty bound to involve everybody, including your radiologist, your pathologist, radiotherapist, and the medical oncologist. But still, surgery is the mainstay. You can have radiation and chemotherapy also. Okay. So when we talk about treatment philosophy, as I said, surgery is the mainstay. Since 1985 onward, there was an NIH, National Institute of Health, United States, consensus in 85. I remember this very well because I got my fellowship in 82. And it wasn't there when I got the fellowship. And when reading up further, as a registrar, I found this thought coming across that was mentioned that you should not amputate sarcomas, limbs. So they said limb preservation is important. The simple rule is that remove the tumor completely with 1 to 2 centimeters margin, normal margin around it. Preserve bone, preserve muscle, preserve neurovascular bundle. And so they made an exception. Muscle, of course, you can knock off as much as you want, even though it has a functional element, but you don't preserve too much muscle. But in preserving bone and neurovascular bundle, if you can shave the tumor off these structures, it is permitted now. Okay, the simple reason being that we have advances in adjuvant treatments, which will not impact the overall survival of the patient. Even if you leave some what it essentially means that if you leave a microscopic amount of disease on the neurovascular bundle, you can still deal with it with radiotherapy or chemotherapy. So how is all this made possible? I mentioned this again, the better imaging. We now have a very clear idea because of soft tissue definition as to how much you can take out and how much you cannot. If the MRI suggests that there is a degree of invasion of the neurovascular bundle where you cannot shave it off the bundle, you can give radiotherapy for downstaging. You can also, if it's very close, you can give a pre-op radiotherapy and get away with smaller margins than 1 centimeter. And we have advances in limb reconstruction, which has reduced the amputation to a large extent. Okay, these are the important things. When we talk about limb reconstruction, I'm not going into the excision or the technique of excision. If you have any questions, specific doubts, I'm sure we're all here, myself, Rajesh, Shrikant, and Ravi, we can all deal with it. When we talk about limb reconstruction, we know what are the kind of reconstructions that are in vogue now, which prevents or avoids an amputation. Quickly, what are the structures that they can reconstruct in a limb now? Okay, vascular construction. Anything you can, but why didn't you just mention it? That's why I clicked and got the answer, because I need quick answers. Okay, yeah. Vascular reconstruction is pretty straightforward. Nerves, as much as possible, are preserved, but you can even cut it off where it is deeply infiltrating and put a graft to get the function of the nerve. Bone, you can have, if a partial cortical excision is done, you can put grafts to strengthen the bone, but you can cut off the whole bone and put a prosthesis between the proximal and the distal parts. This is a very big thing in sarcoma surgery now, and we are specialists. I know 1 or 2 in Bangalore who are doing very good work in this field. In soft tissue, you sacrifice muscle, which will sometimes reduce the mobility, but you are preserving the limb and you're not compromising the outcome. You need to use either rotational or free flaps to get proper cover for that limb. Okay, these are all very, very commonly and routinely done in this. Amputations are very rare, but still you will end up with situations where you cannot avoid it. Large tumors involving many vital structures, it's completely invading the bone, it's very difficult to reconstruct the whole thing. Distal tumors on the hand and feet, for example, you cannot reconstruct so many tendons and so many small muscles and things like that. So you'll end up with an amputation. When the functional outcome predicted are poor, this usually happens when you have large tumor, taking away a large muscle mass. So even if your bone is normal, your blood vessel and new nerves are normal, they have no muscle to act on. And so you suspect that with such a big resection, that you may end up with a very poor outcome in terms of mobility. The patient may do better by, with an amputation and a good prosthesis. So that's a call that the surgeon has to make. And please remember, all these are very expensive. These prostheses that you put and these extensive surgeries that you do. And you will, in this country particularly, come at economic factors, socio-economic factors, where I think it'll be foolhardy to give them a reconstruction. Also remember that these things have a prolonged period of rehabilitation. It's all very well we say we reconstruct, but their rehabilitation and their motivation, the dedication to get better has to last years, if not months. And it costs a lot of money. The physiotherapy and the whole works costs a lot of money. And so you really have to think hard before you, casually recommend reconstruction. Okay. I will run through the radiation and the chemotherapy part of it. It's an important adjunct, but not the primary treatment. Primary treatment still remains surgery. Its use depends on the grade, size, and the adequacy of excision. Even if you have had a very adequate excision, if the grade is high, as determined by the pathologist, it will be probably safer to give radiotherapy. All guidelines clearly tell you that if the tumor is T1, less than 5 centimeters, of low grade, and you have achieved full excision, no further treatment is required. That's about the only thing which is definite. Everything else is dependent on the feeling of the surgeon and the members of the multidisciplinary team. Okay? If you have a low-grade tumor even, you have excised it completely, but you think the margin that you have excised is less than 1 centimeter, then you need to have radiotherapy. Okay? Now, radiotherapy can be either, I don't go into the details in it, but tell you just the outline so that you understand that these things exist. It can be pre-op, post-op, or both. And it can be an external beam radiotherapy, brachytherapy, where you put needles into the tumor and try to shrink it, most often used in post-op situation, or one of the more modern intensity modulated radiotherapy, which reduces the morbidity of the process, right? I told you about the MRI definition of the soft tissue definition. If you think that you cannot get away with the resection, we can give a pre-op tumor for downstage. And lower dosage is generally given in this, so you have a lower toxicity. And because the patient is looking forward to an operation after this, there is better compliance. But please note that the downside of a pre-op radiotherapy is higher wound complications. They don't heal well, infection rates are higher. Post-op is a more localized kind of radiotherapy, but because they give a higher dose, remember you're mostly giving it for inadequate excision. So the radiotherapists are more aggressive, so there's a higher toxicity involved in it. And whatever you do, it hits the muscle also. There is a myositis associated with your radiotherapy, and there is a higher, and they can even have a periosteal reaction and the joint effusions and things like that. And so if you have a post-op radiotherapy, there is a higher functional impairment. And in certain situations for downstaging and advanced tumors, you can give both pre-op and post-op radiotherapy. All right. Chemotherapy can be given in neoadjuvant or adjuvant situations. Most of the time, doxorubicin, ifosfamide, and mesna are the medicines that are given. Newer, of course, whenever you talk about newer things, it is targeted therapy. It may be targeted chemo. Rebectedin is a common. I'm just telling you what's in the books. I have no personal experience of this. And of course, in targeted immunotherapy kind of a thing, monoclonal antibodies, you can use imatinib, sorafenib, and everolimus. These are the things that are there. I have put these slides up not because I expect you to know this. Definitely, I don't expect you to remember these names or give dosages. But you must know, what should you know as a surgeon? Why do you even want to know this? Why did I even put this slide up for Nikita?
So, some of the tumors are chemosensitive. In those, we can use
So
chemotherapy.
all
These are
you
the
have
newer
to,
modalities.
All
Without
you have,
surgery.
correct, not without surgery. This will be in addition to surgery or palliation, of course. If there is metastatic disease, palliation is being considered. But as a surgeon, all you have to know is that if you have a higher grade tumor or if there is any suspicion that you have not removed it completely, if you shaved it off important structures, please get a consult with a radiotherapist and a medical oncologist so that you, as a team, you decide what needs to be done further. Okay, and of course, these things, the other reason you have to know is that as surgeons, you should have explained all this to the patient before you take them up for surgery. Tell them that this is multimodal treatment. You're doing one part of the treatment. And it is very, very likely that you will be asking more surgeons, more specialists to get involved as the treatment progresses. Okay, so there are two other things that you need to know about when we talk about sarcoma. One is isolated lymph perfusion. Unresectable large tumor, you want to downstage it, you can do it. The advantage is that there is no systemic toxicity. You cannulate the artery and the main vein of the limb, put it into a circulating machine, just like a heart-lung machine, for example. Put a tourniquet proximal to where you have cannulated the vessels and tighten it up so that none of the blood enters the main circulation. And then the two common compounds used are TNF alpha, tumor necrosis factor alpha, and melphalan. And if you have the facility, a lot of equipment is required and it costs a lot. You can have hyperthermia, heat up the tissues to 40 degrees, which makes it more chemosensitive, and it works locally on the tumor and downstages it. Lymphadenectomy is very, very rare. As you said, it is usually seen in synovial sarcoma, abdominal sarcoma, vascular sarcoma, and there are 2 or 3 more. Clear cell was mentioned. Yes, I agree with that. Again, in unresectable large tumors. Okay, this I'm sorry, this is a copy paste problem. I copied that and pasted. Please ignore the last 2 lines. It should not have been there. Okay, these are the only 2 lines that are use it in unresectable large tumor. No, not even this. These are seen in lymphadenectomy. These are seen in these cases, and you just have to look at which groups are involved and do a block dissection. And before you do a dissection, what I meant to say was that you must get an that is where FNAC can be used to see whether it is really a reactionary lymph node or whether there is tumor in it. Okay. Surveillance is an absolute must in any kind of sarcoma or even large benign soft tissue tumors. As I mentioned, the standard recommendation is to do a physical examination and a chest CT every 6 months for the first 3 years, and maybe every year for the next 6 or 7 months until about 10 years. Okay, and if you have a recurrence, consider repeat limb sparing. This is the interesting thing. It doesn't mean that if you have a recurrence that you need to go for an amputation. A repeat limb sparing surgery is enough. And for isolated lung mets, people have done metastatectomy, just like in cancer of the colon. If you have isolated lung mets, this has also been tried. Otherwise, you just have to do a palliative chemotherapy. And if you have a large fungating mass, even though you think it is very drastic, even if they have metastasis, you have to do a palliative amputation and a palliative chemotherapy to relieve the patient of the pain and the nuisance of a fungating mass. You may say, if he's got just a couple of months to live, why put him through an amputation? But you may see situations where that kind would be justified. Again, it has to be done in consultation with the patient, having given a very, very important thought, very serious thought to the process of an amputation. All right, so I think that's all I have to say. Yes, that's all I have to say. Now, questions from students, please. Doubts, questions, and comments also from students. Go on.
Sir, what I've read is avoid drains when you excise or incise for biopsy. So what is the reasons for that?
Tracking, tissue tracking, just like incision. You will have cancer cells, and if you put the drain, you put the you pull the drain out through another incision, right, or another hole.
Okay,
And
okay,
the
sir.
whole track will be seeded by the tumor. So when you go for the definitive excision later, you will have such a huge, wide incision that you can't close it.
Okay.
That's why you don't put drains.
So even after wide excision also you should avoid, sir?
No, I'm not talking about wide excision.
Okay.
Not, when you have a complete excision, a large, wide excision, you can use a drain, because at that time, your idea is that you have completely cleared the tumor.
Yes, sir.
Yeah. Any other questions? All right. If not, invite comments, closing remarks. Srikanth?
Excellent question, sir. Thank
Okay.
you.
Anything to add?
No, sir, nothing to
All
add.
right. Rajesh?
Yeah, we read about Mesna somewhere else. I'm just interested whether the students know. Mesna
Inflammatory
was
bowel
known for
disease.
me for soft tissues.
Inflammatory bowel disease, IBD.
Mesna, is it?
Yes, sir.
No, I read it to prevent hemorrhagic cystitis those days.
Yes, sir.
That
Even
was
there, yes, sir.
cyclophosphamide.
Yes, sir.
Cyclophosphamide and
Cyclophosphamide, and yeah, that was a much common use for me.
Correct. That's true. That's true. All right. Ravi, your closing comments, and then we'll close the session. Yeah.
Yes, the interesting thing is the novel Final Diagnosis by Arthur Haley. It was a very iconic book at that time.
Joseph
And
Pierce.
in that, the young pretty nurse called Vivian Loberton is diagnosed with a soft tissue tumor. And unfortunately, she's in love with the orthopedic registrar who has to perform the amputation.
Amputation.
So it used to be the case at that time. Now I think.
And the report comes benign, sir.
Yeah, that's also true.
And the report comes benign. The amputated limb, the report is benign, sir.
Yeah. So I think the message is very clear. It is very comprehensive and very practical. Thank you, sir.
Thank you. Thank you very much.
And one more tomorrow there is class on nutrition, which is this one enteral and parenteral and immunonutrition. If would welcome everyone to join, and your comments will be very appreciated. Thank you.
I have to apologize because I think the last time it was scheduled, I scheduled some other meeting, not aware that this meeting was on. But anyway, we'll come tomorrow. There was you sent a journal for Journal Club. When was that? Is it already over or?
No, sir. No, it is there.
No, sir. 24th. 24th.
Okay, I'll try and join that. I'll come tomorrow. I'll try and come tomorrow.
Thank you.
All right. Thank you very much,
Thank you.
ladies and gentlemen. Good night. Good night.